Good evening, all of you. Could you just confirm
Good
if
evening,
I'm
sir.
audible and visible, including my screen?
Yes, sir.
Thank you so
Yes, sir.
much. Thank you for confirming. So, welcome again. I'm Dr. Jazeer, your dermatology faculty. Hi, good evening, Parul. Thank you for confirming once again. I hope all of your preparations are going fine. You are in the middle of your preparations, right? So, I hope it's going top notch. So I'll just tell you what is the plan for the day. So this is not test and discussion, but today, as you know, I'm going to have a short discussion about some of the important image-based questions in dermatology. Okay. So this subject, dermatology, as you know, all the PYQs or whenever you learn derma, it's full of images. So it is very good that you will be, refreshing some of those images time to time, because the more images that you see, the more you'll be able to recollect it on the day of the exam. So without wasting much time, I'll tell you the exact plan for the day. I have 25 images today that I'll be discussing with you. And for all the 25 images, I have given you certain clues. So I'll just read out the clues. I'll zoom the image for you. So what I would prefer is just let me know in Telegram or in YouTube with your answers, like what is the exact diagnosis. So let's take it like a game and let's see how much you're able to do it. If all of you are ready, shall we begin? I suppose everything is fine. So yeah. Chalo. So let's start now. So I'll start with the first one. Okay. So the image is given here and the clue is erythematous plaques with silvery scales. And you find auspit sign here as well as Koebner phenomenon. Now what I'll do is I'll just zoom this image for you. It's a spot diagnosis. You can see a red color plaque. There are some silvery white scaling. And the clue for you says that the patient shows auspit sign and Koebner's phenomenon. How many of you are able to answer this one?
Yes, yes.
Very good. So this one is going to be psoriasis, right?
Psoriasis, sir.
Excellent. Very good. So please remember, whenever in the exam, when you see this kind of an image where these are erythematous plaques, okay, these are red color plaques, and these reddish plaques, they're always filled up with whitish scaling over it. And usually, where do you find these lesions in psoriasis? Is it over the flexural aspect or over the extensor surfaces? That is also a major differentiating factor. Where do you find the lesions in psoriasis? Is it over the flexures? Yeah, extensor surfaces. So remember, it is
Extensor.
yes, excellent. This is usually seen over the extensor surfaces as well. So as all of you have told it right, this is going to be psoriasis. Now, we are beginning this discussion with psoriasis because every FMG exam, just go back, check the topics that is being asked. Psoriasis is one such topic which is definitely asked. Okay, you get an image anywhere in the body with these kind of plaque lesions with silvery white scaling, the answer is going to be psoriasis. Now, in the last exam, they asked you about something similar to an auspit sign. It's a part of it, which is called as a grattage test, isn't it? So the additional points that you will remember here is a grattage test. Like what happens in a grattage test? You take a glass slide, you're going to scrape over the lesions, isn't it? So once you scrape over these lesions, the scaling, it becomes more visible. So there's an accentuation of the scaling. It's called as grattage test. And once you continue scraping the lesions, you will be able to see some pinpointed bleeding spots like this. Small bleeding spots. Now, what are these bleeding spots, or what is the name of the test that I'm mentioning here? You scrape over the lesions and you find these bleeding spots. Yes, Mohammed, you're also right. Excellent. So what is this test? Psoriatic plaques के ऊपर आप scrape करो with a glass slide, and once you continue the scraping, you find pinpointed bleeding spots. This is what we call as a auspit sign. It is called as a auspit sign. And what is the last one? यहाँ पे जो बताया था, this is Koebner phenomenon. What is Koebner? Anyone? I'm sure by this time you must have gone through these topics. So just try to recollect. Let's try to give our memory some exercise today. So what is Koebner phenomenon? So any patient, yeah, somebody is speaking. Go ahead.
New lesion on the
New lesion, correct, at the
on
site
trauma.
of trauma. Okay, so whenever there is a trauma, if the patient develops a new lesion, it's called as a Koebner phenomenon. So Koebner phenomenon, this can be seen in multiple diseases like lichen planus, vitiligo, and psoriasis. Okay, these are the three diseases which you can remember. So in all these diseases, we can see this condition or this phenomenon which is called as Koebner phenomenon. So whenever there is a trauma, the patient will develop new skin lesions at the site of trauma. It's called as Koebner. So now let's move to the second one. The second image says that it's a purple polygonal papules, purple colored polygonal papules, where you can also find 𝐌𝐞𝐝𝐿, and there is some association with hepatitis C. I'll zoom this image for you. Since it is an image based discussion, just see the image now. Now you're seeing an image like this. The question itself says the color is not red, the color is purple, isn't it? So there are violet color or purple colored papules which you can find. And see this lesion. Always when you see an image, try to describe. Where do you find these lesions here? It is somewhere here in the wrist region. So this is going to be flexural aspect. So what is the name of this disease where a patient develops purple colored plaque lesions or papules over the flexural aspect along with 𝐌𝐞𝐝𝐿? Anyone?
Lichen planus.
Lichen planus. Excellent. So this is called as lichen planus. So this is lichen planus. So very good. So these are two very important topics which comes under papulosquamous disorders, and every time they confuse you between psoriasis and lichen planus in the MCQs as well. So remember, psoriasis will give you red colored plaques, whereas in lichen planus what you can see is purple colored plaques as well as papules, and you can find silvery white scaling when it comes to psoriasis. But what is the type of scaling that you can see in lichen planus? This is called as the 𝐌𝐞𝐝𝐿. Okay? And lichen planus, the infection that is closely associated is going to be hepatitis C. So yes, Mansi, very good. Koebner phenomenon is also called as isomorphic response. Excellent. So isomorphic phenomenon is another name for Koebner phenomenon. So that is also a very good thing to add on. So this is clear. So now let's jump to the next image now. So in the next image, the clues for you says herald patch and a Christmas tree pattern. So these are the two clues for you. Okay, herald patch, Christmas tree pattern. I'll just zoom this image for you now. Now, why does the examiner says that the lesion is having a Christmas tree pattern? Because just like a fir tree, this is how the lesions of this disease will appear over the skin. Now, I need a quick response in the chat box or by voice. Can you answer what is this one? Herald patch.
Pityriasis. Pityriasis.
I heard Pityriasis. I'll give you half marks. Please complete the entire name.
Rosea. Sir, Pityriasis rosea.
Super, super. So this is called as Pityriasis rosea. So why did I say I'll give you only half mark if you just answer it as Pityriasis? Because we have too many Pityriasis in dermatology, right? So Pityriasis versicolor, isn't it? Pityriasis rubra pilaris. So Pityriasis, different types of Pityriasis can be seen. This is Pityriasis rosea. This herald patch, which you can find in Pityriasis, this one is also called as mother patch. It is also called as a mother patch. Now, a very quick question for you. Now, is there any sign that is associated with the scaling that you can see over a herald patch? The clue is the scaling is seen over the periphery of the lesion. So if this is the lesion in Pityriasis rosea, which is called as the herald patch, the scaling can be seen over the periphery of this lesion. And since the scaling is seen over the periphery of the lesion, does it look like any curtain? What curtain is it? Yes, very close to the answer. Can you answer it? What is this? The sign that is associated is called as the hanging curtain sign. It's called as the hanging curtain sign. Okay, that is about Pityriasis rosea. It's called as a hanging curtain sign. Christmas tree pattern can also be seen. The first lesion to develop is called as a herald patch or a mother patch. Clear? So now let's go to the next image now. In the next image, the clue for you is the question says it is a annular lesion, which means rounded lesion with a central clearing. And very important clue that I've given you is on a KOH test, that is a potassium hydroxide test, you are able to see a hyphae. So I guess all of you know that in a KOH test, if you are able to see a hyphae, it's going to be a fungal infection, isn't it? So what is the fungal infection that we are talking about here? And this is an image zoomed in for you. Waiting few seconds for you. It's not eczema. Please remember, KOH is never positive when it comes to eczema. If KOH is positive, think in lines of a fungal infection. And why am I saying that it's an annular lesion, round lesion? Do you want a common name for this one? So I'll give you one more clue because I want all of you to answer. Commonly, we call it as a ringworm. The common name for this condition is a ringworm. Now I would require this answer from you. It's okay to make mistake, but give it a try. Tinea. Yeah, this is called as Tinea corporis. Okay, Tinea corporis. So remember, why do we call this fungal infection as a ringworm? We call this as a ringworm because it is going to be round in shape. That is what we call as an annular shape. In annular shape, you can see that even in this condition, the scaling is present towards the periphery of the lesion, just like in Pityriasis rosea. But this in Pityriasis rosea, if you do a KOH test, will you get this KOH as positive? The answer is no, because Pityriasis rosea is not a fungal infection, whereas this one, that is ringworm, is a fungal infection, and this is called as Tinea corporis. It's called as Tinea corporis. I hope it makes sense. So very good, Dipendra. You're answering it right. It's called as Tinea corporis itself. So thank you so much for responding. So shall I move to the next one? All good? So now let's see the next one. So in the next one, the clue for you is these are depigmented patches in the skin. And very importantly, there is one more clue which says that there is an absence of melanocytes. A deep pigmented patches, absence of melanocytes. And let me zoom this image for you. So whenever we see any image, please try to describe. It is a well circumscribed lesion. It's a well circumscribed lesion which is depigmented, or let us say hypopigmented. But the question itself says it is going to be depigmented, right? So it's a depigmented lesion that you can see probably over the forearm. And the most important clue is there is a complete absence of melanocytes. Now, what is the function of a melanocyte? We all have melanocytes in our body, and this melanocyte basically imparts color to the skin. So when there is a destruction of the melanocyte due to some autoimmunity, that leads to this disease. Deependra is already answering. Musaddiq is also answering. Anybody else who would like to answer? Very good. Excellent. So this is vitiligo. So what is happening in vitiligo? Because in vitiligo, this is a autoimmune disease. So there is an autoimmune destruction of the melanocytes. That is the reason why the patient would end up in depigmented skin lesions. Clear? And vitiligo has been also been asked in your exam. So in case you get a vitiligo which does not cross a midline, a bonus question for you. So if a vitiligo lesion does not cross midline, what is it called? Anyone? Like, be it in one side of the face, one side of the neck, one side of the thorax, it is not crossing the midline and you see a deep pigmented lesion. So vitiligo that do not cross the midline, please remember, this is called as segmental vitiligo. So this is called as a segmental vitiligo. Excellent, Kishore. So Kishore is answering it right. This is called segmental vitiligo because this is a type of vitiligo which is going to follow the nerve roots or the dermatomes. That is why we call it as dermatomal or segmental vitiligo. Because in one of your exams, you got an image of a neck with one side of the lesion being depigmented. They asked you what is the diagnosis. The exact option given in your MCQ was a segmental vitiligo. Okay? That is the reason why I was asking about it. So now let's go to the next one. You find hypopigmented macules, and there is a mention about KOH once again. In the KOH, you can find spaghetti and meatballs. I'll zoom the image for you. So this is the image. So what I can see in this image is, I'll describe the lesion for you. I can see that there is an adult whose upper back is having a hypopigmented patches over the upper back. A lot of hypopigmented patches. Patches is also there, macule is also there. But the clue here again is the KOH. Whenever KOH is positive, what is that you're thinking about? You are thinking about a fungal infection. So what is a fungal infection here?
Tinea versicolor.
Amazing. That's nice. That is the right answer here. So this is called as Tinea versicolor. Versicolor. So this Tinea versicolor is having one more name, and that name is again called as Pityriasis versicolor. So another name for Tinea versicolor is Pityriasis versicolor. That is why I told you we have a lot of pityriasis. Okay, here also it is called as Pityriasis versicolor. Now, before we go to the next topic, just few sentences here is, see this word versicolor. Versicolor means different colors. So tomorrow for your exam, you may find that there is a hyperpigmented patch, a darker skin, or it can be a lighter skin, hypopigmented patch. So it can be versicolor. It can be either hyperpigmented or hypopigmented. So don't get confused if you see a hyperpigmented lesion. So even if it is hyperpigmented, if the KOH is showing spaghetti and meatballs, which means the fungal hyphae as well as the spores together, the answer is going to be Pityriasis versicolor. So good going, whoever is answering it right. So I hope you are able to revise and recollect all those things which you have learned. Now let's move to the next image now. Now this next image, the question says the clues are flaccid bulla, oral ulcers, desmoglein 3, Nikolsky positive. Flaccid bulla, oral ulcers, desmoglein 3, Nikolsky positive. And I'm zooming this image for you. Now what would have happened in this patient is, we are seeing an image of a patient who might have had bulla here, here, isn't it? Multiple bulla would have been present, but since it is a flaccid bulla, these bulla must have eroded. Okay, there is a breakage of this bulla. So once there is an opening up of the bulla, what we can find here is these are erosions. Okay, you can see some crusting as well. There is some erosions here. But the important clue is that this patient had bulla over the trunk. The patient had bulla and the patient is having oral mucosal erosions as well. What is the answer here?
Pemphigus vulgaris.
Pemphi, come again? Yes.
Pemphigus.
Yeah. So the names, the terminologies in dermatology may be confusing, but it's good. So you have answered it right. This is called as Pemphigus vulgaris. Okay, this is called Pemphigus vulgaris. Excellent. Now, the biggest thing is that every time when you find a vesiculobullous lesions, so Kishore is also answering it right. Very good, Kishore. So here what you have to make sure is whenever you see any MCQ which says that the patient is having some bulla in the body and along with that oral mucosal erosions, this is a differentiator here. Whenever there is oral mucosal involvement, answer is always Pemphigus vulgaris. And Pemphigus vulgaris is usually due to desmoglein 3 defect as well as desmoglein 1 defect in the later stage. Okay? So in the later stage of the disease, desmoglein 1 can also be seen. Now, what is this sign which is called as 𝐒𝐿𝐄𝐝? So why did I give you a clue that 𝐒𝐿𝐄𝐝 is positive? 𝐒𝐿𝐄𝐝 sign means, I'll just zoom this image for you because we have discussed about multiple signs today already. We discussed auspice, we discussed Koebner phenomenon. Now we are going to discuss about 𝐒𝐿𝐄𝐝 sign. Imagine that the patient is having a bulla here. It's a flaccid bulla. And if I apply a tangential pressure over the skin, what happens? Since it's a flaccid bulla, the skin may get peeled off, isn't it? This is called as 𝐒𝐿𝐄𝐝 sign. So whenever you have a flaccid bulla, like one of a very easy example can be a burns patient, isn't it? So in such cases, whenever we apply a tangential pressure over the skin may get peeled off. It's called as 𝐒𝐿𝐄𝐝 sign. Okay. Shall I go to the next one? Next one is also a image of a bulla, so which means we are still in the same topic. But here, the exact opposite is given in the clue. It's a tense bulla. It's not flaccid. Flaccid means breaks easily, whereas tense means it doesn't break easily because it is a subepidermal blister, which means the bulla is formed below the epidermis, isn't it? And the 𝐒𝐿𝐄𝐝 is negative. Matlab, if I apply a pressure, tangential pressure like this, the bulla is not going to peel off. This bulla is tense, it doesn't break. Who can answer what is this one? Very good, Krishna. This is called as bullous pemphigoid. Excellent. Charan is also answering. So this is called as bullous pemphigoid. So for your exam, so you are not going to make any mistake in these kind of topics because any MCQ which says that there is a bulla along with oral mucosal erosions, you always think about Pemphigus vulgaris. Why does the bulla break very easily? Because the bulla is formed within the epidermis. So the MCQ will say it's an intraepidermal bulla. Whereas whenever there is any question about bullous pemphigoid, it will mention it is a subepidermal blister, which means the blister or the bulla is formed from beneath the epidermis, below the epidermis, and this can be seen in bullous pemphigoid. Clear? Now, there is only one simple sentence here. It says transient itchy wheals. Transient means it comes and disappears. Itchy, all of you know, the patient would be feeling this sensation of itch, and you can find wheals, and I'll just zoom it for you. So once I zoom this image, what I can see here is the patient is having a lesion over the skin, which looks like there is some edema underneath the skin. See this part, isn't it? So there is some edema underneath the skin. So this is called as a wheal, transient itchy wheals. Spot diagnosis. Who can answer? Musaddiq, excellent. Super. Super. Excellent. So all of you are answering it right. So Charan is also answering. So this is called as urticaria. So in the cases of urticaria, what happens here is it is just like any other allergic reaction to the body, right? So when a patient says that the patient consumes seafood, they consume some grape juice or something as such, or there's a change in environment, after that the patient is developing these kind of itchy wheals over the skin. The answer is always urticaria. And by definition, what happens? They usually disappear within 24 hours as well. So these are urticaria which usually disappears within 24 hours. But when the patient develops urticaria, the patient will feel intense itching and it can be seen anywhere in the body. So for your exam, see the dangerous part or the area where you have to stay focused is today in our discussion, I'm showing you some other body part. On the day of exam, if you find some urticaria lesion over the face, still you should be able to mark the answer as right because it can be seen in any part of the body. Whenever you find edema underneath the skin, the answer is going to be urticaria. So the next one, recurrent hyperpigmented patch, which is occurring at the same site. I'll give you one more clue. Every time the patient takes an NSAID like a piroxicam, the patient is developing a hyperpigmented patch. And this hyperpigmented patch, it reappears at the same site every time the patient takes the same drug. I've given you enough clue. Now I'll zoom this. Very good. It's called as a fixed drug eruption. Hi, Samir. Very good. Wiki, all of you are answering it right. So this is called as fixed drug eruption. So here we'll label this one as fixed drug eruption. So you have to go with a very clear concept. What happens here? Patient is taking a drug, any drug, let us say diclofenac. The patient is taking a diclofenac tablet. The patient is developing a hyperpigmented macule or a patch, sometimes over the lips, even over the genitalia or anywhere in the body. So if you see this kind of a history that this lesion reappears at the same site every time the patient takes a drug, the answer is going to be fixed drug eruption. So glad that all of you are answering the right answers. So now let's go to the next one. Next one seems to be easy. Let's see how many of you are getting it right. Burrows in the web space and there is intense itching during the night time. And there is some image that is given of the hands. So examiner seems to show you something like this. Scabies. Very good. Scabies. Excellent. So here, this one is called as scabies. So we know that scabies, this is caused due to Sarcoptes scabies, isn't it? So there is some mites underneath the skin which causes intense itching. So what happens is every time we get a patient of scabies, you will ask the patient for sure that does the close contacts or the family members have the same symptom. Most of the times they will say that, huh, I got this thing initially, but within few weeks, what is happening is the entire close contacts is also having the same symptom and the patients are unable to sleep during night. So this one, which we call it as night itching, this is called as nocturnal exacerbation. So there is a nocturnal exacerbation which happens in the patients of scabies. And this one, the most typical lesion that you can find in this disease is called this one, that's called as a burrows. Okay, burrows, very typical. Any MCQ, be it this long MCQ. But if you find this magic term, burrows, answer is always going to be scabies. So Danish was also answering it right in YouTube. Excellent, Danish. So now let's go to the next one. Umbilicated papules, and it's a pox virus. In fact, there is not even a requirement to give you a clue here because this is a spot diagnosis.
Sir, molluscum contagiosum.
Super, excellent. So this is called as molluscum contagiosum. This is molluscum contagiosum. So why am I saying that molluscum contagiosum doesn't require a clue? Because it's a spot diagnosis. The reason is we see this image and one thing strikes your eyes, isn't it? So what is that? You can see that there is a central umbilication. So this is called as central umbilication, which is very typical what you can see in molluscum contagiosum. Now, one more bonus question I would like to ask all of you is, imagine that this was a child who got this molluscum contagiosum. Now, after several months or after several weeks, the mother says that it was just one lesion. Now this has become 2, 3, 4, 5, 6, multiple lesions which is appearing one after the another. What is the name of the phenomenon I'm talking about? Anyone? Very close. Whoever answered it, Cobner, you're almost there. But it should have been pseudo Cobner. Okay, please don't make a mistake. Cobner means what we can see in LVP, lichen planus, vitiligo, and psoriasis. So that is appearance of new lesion at the site of trauma. Yahan pe, what we are discussing right now, this one can be called as pseudo Cobner. What is happening in pseudo-Cobner or pseudo-isomorphic phenomenon? Here, new lesions, it appears not because of trauma, but due to auto-inoculation of the virus. Due to auto-inoculation of the virus. Okay, so what must have happened is, this is a child who has got molluscum contagiosum. It's again caused due to a pox virus. So what do? Every time you get a pimple, what are you doing? You always try to pick the lesion, right? The same thing happens in a child or in any adult. Whenever you get a lesion in our body, you have a tendency to touch. And once you touch this and then touch the adjacent skin, what happens? There is an auto-inoculation of the virus to the adjacent sites in the body. And that is why you develop multiple such lesions. Auto-inoculation of the virus is equal to pseudo-Cobner phenomenon can be seen in viral infections. I hope it's clear. So now let's go to the next image. The question says verrucous papules, HPV virus, human papilloma virus, and it's not Cobner. You can see pseudo Cobner phenomenon. You can see pseudo Cobner phenomenon. I'll just zoom this image for you. Anyone? What is this? Anyone? Give it a try. It's okay to make a mistake. What you can find is verrucous lesions. Verrucous means these are warts. Okay, these are warts. So it's not a difficult thing. So this one is called as verruca vulgaris. This is called as verruca vulgaris. See, what do you mean by vulgaris? Vulgaris means the most common. This is the most common type of warts which you can find in our body. And this warts, they are caused due to human papilloma virus. And why do we say it is verruca vulgaris? Because these warts, they have a rough surface. Okay, if you just zoom it again closer, you can see some cauliflower like lesions, isn't it? So these are called as rough surfaced exophytic growths that you can see. It is caused due to human papilloma virus. It's called as verruca vulgaris. Verruca vulgaris. So now let's see the next one. Surprising that I didn't get an answer for verruca vulgaris, but on the day of the exam, all of you are going to get this right. Yeah. So now let's see the next one. Patient is having black patchy hair loss. There are some black dots can be seen in the scalp, and it responds very well to griseofulvin. Now, what is griseofulvin? Is it an antibiotic? Is it antiviral or is it antifungal? Griseofulvin. So we know very clearly that so this should be a fungal infection. So what is the fungal infection we are talking about? Where a patient can come to you with a patchy hair loss. There are some black dots. So why there is black dots? Because the hair breaks close to the scalp. So when the hair would break very close to the scalp, this is called as black dot. And here the diagnosis should be, should I give you a chance to answer? Anyone? Just give it a try.
Tinea capitis.
Excellent. So that is called as
Tinea capitis.
Tinea capitis. Very good. Kishore is also answering. So this is Tinea capitis. So this is called as Tinea capitis. In Tinea capitis, this is also called as a black dot. Okay, because there are different types of Tinea capitis. Black dot is one, gray patch is another one, Irion is another one, Favus is another one. So in all these cases, what happens? The patient will have a fungal infection of the scalp. That is why we call it as Tinea capitis. Obviously, when you do a KOH, the KOH will be positive as well. And remember, griseofulvin is considered to be the drug of choice in Tinea capitis. It's considered to be the drug of choice as well. So this one is called Tinea capitis. So let us see one more image where you have a patchy alopecia and a exclamation mark here. And I'll just zoom this image for you. This is the image. So it looks like it's a youngster.
Alopecia area.
Very good. Sharon is answering. Anyone else? So this one is called as alopecia areata. Yeah, very good. Alopecia areata. Now, be it the scalp, be it the beard area, on the day of the exam, when you see that there is a patchy alopecia like this, so whenever you find this patchy alopecia, answer is always alopecia areata. So when you look under a microscope, what you can see is this one, which is called as the exclamation mark hair. Exclamation mark hair, because the hair becomes very broad towards away from the scalp, and near to the scalp, what happens? The hair becomes much more thinner. It's called as the exclamation mark hair. Before we proceed to the next image, I'll just ask you one more question and then we'll go to the next image. Okay. The question is, in this patient, can you name a intralesional steroid which can be used? Let's say I want to use a steroid injection at this site for the management. Any answer? No. Good try anyways. So the concept here is that alopecia, so I'll just write down the diagnosis first. So this is called as alopecia areata. So this is called as alopecia areata. Please remember, alopecia areata is also autoimmune disease. It's also an autoimmune disease. So today we learned vitiligo was an autoimmune disease and alopecia areata is also an autoimmune disease. So in this autoimmune disease, what happens? Our body is attacking our own cells, isn't it? So we have to bring down the immunity. So to bring down the immunity, we have to use some immunosuppressive agents, out of which the most commonly used can be a steroid, isn't it? So here, the steroid which can be used as an injection at the site is called as intralesional triamcinolone. It is called as intralesional triamcinolone. In any other conditions, have you ever used intralesional triamcinolone as an injection? Probably surgery, sometimes in derma.
So keloid.
Amazing. Okay, that is called as keloid. Very good. So in keloids also, we use this intralesional triamcinolone, which is a steroid. So please remember, in alopecia areata also, we can use intralesional triamcinolone. Excellent. So now let's move to the next image. So the next image says that 𝐒𝐿𝐈 macules, axillary freckling, leash nodules. These are the three clues for you. Let's zoom the image now. So this is the image. what I can see is there is a well circumscribed brown colored hyperpigmented patch over the skin. So this one is called as FMGE calm. Okay. Now, where do you find the combination of all these things? 𝐒𝐄𝐈𝐀𝐋, axillary freckling, very pathognomic sign, and leash nodules.
Sir, NF1.
Super. This is called as NF1. So this can be seen in neurofibromatosis 1. So this can be seen in neurofibromatosis 1. So Musaddiq is also answering it right. So this is called as NF1. Remember, this one, that is axillary freckling, which you can see in this patient. Because 𝐒𝐿𝐼 it can be seen in normal individuals like me and you. Okay? Because seeing a 𝐒𝐿𝐼 does not confirm the diagnosis of neurofibromatosis. But if you find that a patient is having either a inguinal or an axillary freckling, so brownish spots that you can see over the axilla, that's very pathognomical. And what is the sign? This is also called as a sign today. What's the name of the sign? Can you give it a try? Starts with C. If anybody wants a clue. Axillary freckling, which you can see in neurofibromatosis, is also called by a sign which starts with the letter C, R, O, W, E. So this is called as a 𝐒𝐿 sign. Okay. So learn this as well. Axillary freckling in neurofibromatosis. This is also called as 𝐒𝐿 sign. And please remember, in the last FMGE exam, they asked you what is the ophthalmologic manifestation of neurofibromatosis. The right answer was leash nodules, isn't it? Iris hamartomas. So that is the ophthalmology manifestation that you can see in neurofibromatosis. Shall I move further? Next one is, you can see ash leaf spots, facial angiofibromas, and a shagreen patch. I'll just zoom this image for you. There are 3 clues along with this image. So this one, you can see that there is a lesion with a tapering edge, isn't it? That is why we call it as a ash leaf macule. So we can find ash leaf macule. In the face, there is facial angiofibroma, very, very pathognomical. So you see facial angiofibroma, very characteristic for this disease. If you want a clue, this also comes under genetic disorders in dermatology. Anyone? Shagreen patch is another clue. So this is going to be tuberous sclerosis. Okay, this is also called as tuberous sclerosis. So it is another autosomal dominant disorder where the patient can come to you with different symptoms. Yeah, enterobius vermicularis, good name. Okay, he's also answering it right. This is called as tuberous sclerosis. So in tuberous sclerosis, just remember that in case you get a clinical scenario, the clinical scenario, this is called as Warts triad of epiloia. It is called as the Warts triad of epiloia. So why am I mentioning it as Warts triad of epiloia now is because the question can give you multiple clues that the patient is having epilepsy, that is epi. LOI is for low IQ, okay, low intelligence or low IQ, and A stands for angiofibroma of the face. Angiofibroma of the face. So this is how you can get a question of tuberous sclerosis, that a patient who is taking eptoin or phenytoin tablets presents to you with facial angiofibroma and the patient is mentally retarded. Answer, tuberous sclerosis. Clear? So now let's see the next one. Next one needs no explanation. This is a condition where we use this criteria called A, B, C, D, E. I can see that the patient has developed a black colored mole, but This mole is having a darker color here, lighter color here. Okay, the size is increasing, the border is irregular. Now, what is the diagnosis?
Malignant melanoma.
Excellent. So this one is called as malignant melanoma. Excellent. Malignant melanoma. So we usually do not panic whenever we get a new mole, isn't it? But when should we be alert whenever we get a new mole? Is always when you see that there is something irregular about it. Like every time you get a new mole in our body, we have to evaluate it with the ABCDE algorithm, where A stands for asymmetry, okay, B stands for border irregularity, C for color variation, like what you can see in this image, D where the diameter is increasing like more than 6 mm, and E means it is evolving as well. The color may be changing, the shape may be changing, isn't it? So evolving in color, size and shape. This is called as ABCD criteria, and this is done for the evaluation of a malignant melanoma. Okay, very good. So Abhinandan Kishore Kumar is done. So now let's see the next one. Now this is another spot diagnosis, but we can give you a clue as well, because in the last FMG exam you got this thing, isn't it? So let me see how many of you are able to answer. You get a pearly papular lesion with telangiectasia, and there is a local invasion. I'll zoom the image for you. Now time for you to answer.
Basal cell carcinoma.
Very good. Basal cell carcinoma. Enterobias is also good. So remember, in basal cell carcinoma, the most common site where you can find a basal cell carcinoma is mostly the face, isn't it? So in the face, if you find a lesion which is having a rolled up border, and in the center you can see that there is a telangiectasia as well. So rolled up border with central telangiectasia always gives you a clue that it is going to be a basal cell carcinoma. Glad that all of you are able to answer it. So this is called as basal cell carcinoma. So in the last exam, what was confusing was they gave you an image of somewhere in the face, but they tried to confuse you between a squamous cell carcinoma and a basal cell carcinoma. And the differentiating thing which was mentioned in the MCQ was the histopathology. Now, what do you expect in the histopathology of a basal cell carcinoma? The clue is name itself, basal cell carcinoma, which means it arises from the basal cell. Something is happening to the basal cells. Anyone? All of you who answered it right, can you come back to the chat box again or answer what is the histopathology finding in basal cell carcinoma? Remember, it is called as peripheral palisading of the basal cells. It's called as the peripheral palisading of the basal cells, which can be seen in basal cell carcinoma. Very good. Enterobiasis I have already answered. Super. So shall I move to the next one? So moving to the next one. The clue says white membranous coating in the oral mucosa. And you can find pseudo hyphae in the KOH. Now again, KOH, you start thinking about fungal infection. So earlier you saw hyphae when it was dermatophytosis. Now you see pseudo hyphae. So somewhere you can connect this with microbiology as well. And what do you see? White membranous coating in the oral mucosa. Who can answer?
The Candida albicans.
Candidiasis.
So Candida albicans, oral candidiasis, all these things are the right answer. So here this is called as oral candidiasis. It's commonly called as the oral thrush. Okay. And where do you find the pseudo hyphae? You see pseudo hyphae in candidiasis, usually caused by Candida albicans. And this is the image how it looks like, isn't it? So when we use any antifungal mouth paints, let's say clotrimazole. Clotrimazole mouth pain, once the patient will apply, what happens? This fungus will again automatically disappear. Okay, because we use an antifungal agent here. And one question before we go to the next one. What is the type of patients who is more prone to getting a oral thrush or a oral candidiasis? Anyone? Yes, immunocompromised, yes, I agree. But which type of immunocompetent people can also get it? Any idea?
Asthma patients.
Asthma patients, very good, Janisha. So what happens is in asthmatic patients, when they use steroid inhalers, so when they repeatedly use the steroid inhalers, because of using steroids, what happens? It gives a condition that is favorable for a fungus to grow, isn't it? And that is how candidiasis can be seen in the oral mucosa. It's called as oral candidiasis. So remember two things. As first, all of you have said, immunocompromised is also correct. And in immunocompetent patients who are using steroid inhalers, bronchial asthma patients can also develop oral candidiasis. Very good. Now, let's see the next question. Grouped vesicles, erythematous base, Zank smear is positive. And I'm going to zoom this now.
Herpes labialis.
Herpes labialis, says Janisha. How many of you agree with her? Herpes labialis, says Bharat, Antrobias and Kishore.
Yes.
So everybody is agreeing, right? So what is happening here is, remember, on the day of the exam also, don't make silly mistakes, because on the day of the exam, if you find something around the lips, especially if it is a child and all, and if you can find some yellowish crusting, because it can be a close differential diagnosis. When you see yellowish crusting, crusted lesions around the oral mucosa or around the lips, then what you should think about? I'm talking about some very close differential diagnosis here. Anyone?
Sir, impetigo. Impetigo.
Yes, very good. So this can be impetigo. Okay. So not hand, foot, mouth disease, the answer should be impetigo. So if you see some yellowish crusting over the face or anywhere in the body, yellow crusting means golden yellow honey colored crust, think about impetigo. At the same time, if you find some intact vesicles, which is a grouped vesicles on an erythematous base, then think about a viral disease. And what is this virus? Herpes simplex virus. So this one should be herpes labialis. So this one is called as herpes labialis. And the question has also said it is Zank smear positive. Like if it was impetigo, Zank smear is not going to be positive. Now here in Zank smear, what is the finding that we expect in herpes infections? Anyone? What is the finding that we expect in a Zank smear? You know what happens in a Zank smear?
The multinucleated giants.
Very good. So you can find a multinucleated giant cells, isn't it? So Bharat is also answering it right. Very good. So what happens is we are going to de-roof a vesicle. So inside a vesicle, there is some fluid. We collect this fluid into a glass slide. We add some GMSA stain. We examine it under the microscope. You will be able to see multinucleated giant cells when it comes to herpes labialis or any herpes simplex virus infections. Okay, that is why. So here the right answer should be herpes labialis. So now let's go to the next one. This slide, okay, there are some lesions in the genitalia. First lesion that we can find in the genitalia, the clue says it's a rough surfaced growth and it is caused due to human papilloma virus 6 and 11. And I'm zooming the image for you.
Sir, it's condyloma.
Yeah, condyloma, and the remaining part was least confident. Why?
Acuminata.
Acuminata, very good. So there is no confusion
Sir.
here. It is not lata, it is acuminata. Krishna, you are right.
Sir,
Okay.
Sir, what's the difference between condyloma acuminata and varicose vulgar?
No, no. Verruca vulgaris. See, what happens is all these things are caused due to human papilloma virus. So whenever this human papilloma virus causes infection in the skin, we call it as viral warts. Okay, viral warts, it can be seen anywhere in the body, because on the day of the exam, you can see plain warts, planar warts can be seen over the face. You see some rough surface lesion over the palms. These are called as verruca vulgaris. It's the most common. And when you see the same warts over the genitalia, we call it as condyloma acuminata. It is just like how you call tinea infections: tinea capitis, tinea fasciae, tinea barbae, tinea corporis, etc. Similarly, according to the site of the lesion, we name it differently. Okay. So here, this is called as, whenever we find a genital warts, we call it as condyloma acuminata. So genital warts are called as condyloma acuminata. It is caused due to HPV 6 and 11. Here HPV 6 and 11, Lone Bilal, the audio chat is in Telegram. We are going live in Telegram as well as in YouTube. Okay. So here what we see is HPV 6 and 11. This is it a high risk subtype or a low risk subtype?
Low risk.
Yeah, so this is a low risk subtype because it does not proceed into any kind of a malignancy. Because in gynecology, you must have learned that HPV 16 and 18 was implicative of cervical cancer, isn't it? So that was a high risk subtype, but this one is going to be a low risk subtype. Now, many of you, when you were answering it as condyloma acuminata, condyloma you were confident, but acuminata the voice was coming down. Why are you getting confused between condyloma acuminata and condyloma lata? In which disease do you find condyloma lata?
Secondary syphilis.
Are you sure about it?
Yeah.
Okay, so in condyloma lata, very good. It's a highly infectious lesion. Again, seen in the genitalia. It's seen in secondary syphilis. Very good. It's seen in secondary syphilis. Okay, where in condyloma lata, what happens? You may see a flat top lesions in genitalia, whereas here you find rough surface lesions in the genitalia. Okay. So now let's see the next one. Next one is not about any rough surface lesions. It's about an ulcer. Now the question says painless ulcer and a painless lymphadenopathy. And this is the image for you. Bharat is already answering.
Syphilis.
Yeah. How many of you agree? Is it syphilis? Is it donovanosis, chancroid, LGV? So many genital ulcer disease, right? So what is this? This is going to be syphilis. Now, why is this syphilis? This S in syphilis is for silent disease, right? Because here the ulcer is also painless and the lymphadenopathy is also painless. So there's no pain in the ulcer, there's no pain in the lymphadenopathy. This is seen in syphilis. Okay. In syphilis, what is a causative organism? Let's do some microbiology in between. Causative organism? Treponema pallidum. So in this patient, if you get a question in the day of the exam that this is a truck driver who presents to you with a painless ulcer and a painless lymphadenopathy, what is the investigation of choice in this patient?
Dark.
Very good. That's going to be a dark field microscopy. Very good. Excellent. Let's see. It shows that your preparations are right in track. Happy to see these answers now. Okay, so now let's see the next image. Next image says target lesions HSV associated. And I'm zooming this image for you.
Sir, erythema multiforme.
Everybody agree for this answer? Bharat says erythema multiforme. Krishna says erythema multiforme. Is it right? So target lesion. So what your eyes should be able to see is there is a patient whose acral or the extremities of the skin is having something like this. There is a rim of erythema with something in the center as well. So this looks like a target or a bullseye, isn't it? So it is also called as a bullseye lesion, iris lesion, or a target lesion. So this is called as erythema multiforme. It's called as erythema multiforme. Okay. And please remember, the question on the day of the exam may tell you about target lesion, or it can be called as bullseye lesion, or it can be called as a iris lesion. And before we go to the next image, you need to tell me what are the common associations of this condition. The association, it can be either an infection or it can be drugs. Infection and drugs. What are the infections that is associated with erythema multiforme? Give it a try. Infections associated with erythema multiforme. So one of the infection is given as a clue, isn't it? One of the infection is going to be HSV. Another one is going to be mycoplasma. Mycoplasma infections can also be associated. Yeah. So now let's see the next one. This is a patient who is presenting to you with skin sloughing. There are mucosal erosions and pseudo-Nikolsky sign positive. If you want, I'll add one more thing. There is a history of drug intake. The patient has taken some new drug, after which the patient presents to you like this. There is massive skin sloughing. The skin is getting peeled off. For me, it looks like a burns patient, right? But the question says there is a drug history. Anyone?
Sir, SJ.
SSE. Scale syndrome.
Okay, I'm getting correct answer here, wrong answer here. So let's get it right. Okay, so here many of you are getting it right as well. So this one is the most severe type of a drug eruption. This is more likely going to be toxic epidermal necrolysis. Toxic epidermal necrolysis. What is happening in a toxic epidermal necrolysis is the patient must have taken a tablet. After taking a tablet, the patient is developing massive peeling of the skin. Along with this massive peeling of the skin, there is also mucosal erosions. So mucosa means it can be oral mucosa, it can be genital mucosa, or the mucosa of the eyes. So all this mucosa is also involved. So this kind of a very serious drug eruption is called as toxic epidermal necrolysis. So when you have learned this thing, you must have learned Stevens-Johnson syndrome and toxic epidermal necrolysis together. What differentiates Stevens-Johnson syndrome from toxic epidermal necrolysis? Kishore has already answered before.
Involvement of
Involvement of the mucosa, no, because in both Stevens-Johnson,
Area.
yeah, body surface area, okay, because in both Stevens-Johnson syndrome and toxic epidermal necrolysis, the mucosa can be involved. The differentiating factor is, I'll just write it down as well. If there is less than 10% body surface area, you can call it as Stevens-Johnson syndrome. If there is more than 30% of body surface area, you can call it as toxic epidermal necrolysis. The body surface area is what is going to differentiate. Now, just like what Krishna has answered about mucosal involvement, if you find a baby or a child who comes to you like this, massive peeling of the skin without mucosal involvement, then what should be your answer? Yes, very good. That's going to be staphylococcal scalded skin syndrome. So remember, it's usually seen in children. So they may come to you with massive peeling of the skin, but there is no mucosal involvement when it comes to staphylococcal scalded skin syndrome. Okay, so that is it. So I think we have come to the completion of 𝐒𝐿 25 image discussions. So it was very nice interacting with all of you. But it is not likely that they may mention the body surface area in the MCQ. It depends. But whenever you see that there is a massive involvement, then automatically the answer should be toxic epidermal necrolysis. Okay, because Steven Johnson is going to be much more mild. More mortality is associated with 10. It's associated with 10. Patient on phenytoin, fever, or oral ulcer, skin peeling. What's the most likely diagnosis? Here again, this can be Steven Johnson syndrome or toxic epidermal necrolysis. The reason is anti-epileptics, anti-tubercular drugs, all these things. When the patient is going to take any of these kind of drugs, there's a chance that the patient may show you a very severe drug eruption. And that can be TEN or Steven Johnson syndrome. So, Lon Bilal, in this case also, since pseudo-Nikolsky is mentioned, the answer should be more likely SJS or 10. Okay, and yeah, done. So thank you so much for being a very interactive crowd, and we'll try to do more these kind of sessions, because I believe that in dermatology, when you see these images very frequently, this helps you to memorize what you have learned in the past, and keep revising is a key. And please keep revising, see more images, and try to make out the spot diagnosis anytime. Any other queries which you want me to answer today? Okay, thank you so much. So if that
Thank
is,
you, sir.
thank you so much for being a very interactive crowd, and keep learning, huh? Keep learning.
Thank you,
Well.
sir. Thank you, sir.
Thank you.
Yes, sir. Very helpful.
Thank you so much.